Thank you, Professor Haraz, for this introduction. And I much appreciated for Professor Yas Osman for the invitation. And I wish you, and I do believe it is, a very successful workshop. مفتوحة. Bismillah ar-Rahim. Peace be upon you and welcome to our center. I'm Ahmed Elhussien, lecturer of Urology and Laparoscopy in the Mansoura Urology and Nephrology Center, and I'm introducing a short lecture about what's called the LAPDOCTOR Score, which is used for laparoscopic living donor nephrectomy. I have nothing to disclose. First of all, we should know that among different renal replacement therapy modalities, the kidney transplantation remains the gold standard, and many reports have illustrated the overall superiority of living donor nephrectomy compared to the cadaveric. And based on the International Registry of Organ Donation and Transplantation worldwide, the kidney transplantation from living donor rates in 2024 was highest among Turkey and Saudi Arabia, with variable rates among different Western and Eastern countries. Unfortunately, Egypt is not in that list. And as Professor Shell in the first day of this workshop have presented the tips and tricks for lab donor nephrectomy, he stated the importance of routine preoperative evaluation, including the detailed medical and surgical history taking, the full lab investigations, and of course the contrast-enhanced imaging and renal scintigraphy. The technique of laparoscopic donor nephrectomy has been thoroughly investigated in literature. There is a plethora of studies and an endless citations regarding how I do the lab donor nephrectomy. But the question is how to assess the difficulty of the procedure, the surgical difficulty of the procedure. For accurate assessment, the simple answer is we have to create a scoring system. We have to have a scoring system. Any scoring system in the field of medicine can allow the transition of subjective eyeballing into objective precision. And a very commonly used and a classic example for scoring system in the field of urology is in the field of urology in general, the IBSS, the International Prostate Symptom Score. It converted the symptomatology of the patients, the lower urinary tract symptoms, into measurable, quantifiable score. And this score can be used even for assessment of the line of modality to be used for treatment of BPH. But for lab donor nephrectomy, do we really need a scoring system prior to laparoscopic living donor nephrectomy? The answer is yes, because the scoring system, to develop a scoring system, has many values. It identifies the straightforward cases for training programs. It creates more awareness for more complex cases. It helps to ensure the donor safety. We are dealing with a healthy individual who's willingly donating one of his organs, and to avoid any mishaps and any complications. We are dealing with a precious kidney. Any complications, major complication in the graft, can cause us an arm and a leg. That's why we need the scoring system. That's why various tactics have been published in literature about how to preoperatively assess the difficulty for laparoscopic donor nephrectomy. We have the Johns Hopkins study back in 2000, 26 years ago. They relied on certain radiological anatomical parameters and clinical anatomical parameters to assess the difficulty of the procedure. Also, we have the Rotterdam study in 2020. They created a score based on 5 parameters: the gender, the body mass index, the technique of laparoscopic donor nephrectomy, number of renal arteries and veins. And based on the sum of these scores, they categorized the difficulty of performing the surgery into low, intermediate, or high. Also, we have the MAB score, the Mayo Adhesive Probability Score, that assesses the difficulty of the laparoscopic donor nephrectomy based on the thickness and adhesiveness of the peri-nephric fat. And the latest, which is the subject of the topic of our lecture today, is the LAPDOCTOR Score, published by a group of physicians from Italy in 2025. What is the LAPDOCTOR? The LAPDOCTOR is the short for Laparoscopic Donor Nephrectomy Score. This score has been created for 2 main reasons. The current prediction methods rely on certain specific parameters like the body mass index, the peri-nephric fat thickness, certain subjective tools. These are not sufficient. And the second reason is the anatomy is not always predictable. Unexpected difficulties can arise during the surgery, even if the patient has normal preoperative CT. You may be encountered with a sticky peri-nephric fat, complex vascular anatomy, limited working space, and adhesions, creating poor tissue planes. In this study, the LAPDOCTOR score is a multi-parametric scoring system. It does not rely on a single parameter. It relies on demographic data, including the sex and body mass index, and 9 contrast CT parameters to have 11. Each is given from a score from 1 to 3, except for the sex and the body mass index. And the total score is up to 33. So we convert subjective data into precise, objective, measurable data. And the radiological anatomy, the radiological anatomical parameters this score rely on include the upper renal fat tissue density, the pre-renal fat tissue thickness, the retrorenal fat tissue thickness, and the lower renal fat tissue density just below the kidney. Also, the abdominal wall circumference at the anterior superior iliac spine, at the umbilicus, at the 12th rib, together with the peri-umbilical fat thickness and the oblique muscle density. The score is quite complex. It was not easy to put this table in a one slide. Each, as I mentioned, is given from here to there, is given a score from 1 to 3, except for the sex, 1 or 2, and the body mass index from 1 through 4. And the risk stratification based on the sum of these weighted scores of the 11 parameters. The surgery could be standard if the case has low score from 11 to 18, moderate difficult if the patient if the case has a score from 19 to 25, or very difficult with highest score reaching to 33. So back to this study, the LAPDOCTOR, the validation of such a score. This was a prospective multi-center study conducted in Italy in April 2025, including 185 donors from different centers across Italy. It was a double-blinded study. Both the radiologists and the surgeon were blinded to each other outcomes. The radiologists were blinded to the surgical outcome, and the surgeon was blinded to the prediction model outcome. They included 185 donors with mean age 54. 68% were females, 32 were males with mean body mass index 25 kilogram per square meter surface area. And the surgical approach was 41% for hand-assisted lap donor nephrectomy, 37% for pure laparoscopic donor nephrectomy, and 22% with robotic-assisted technique. 82% of the kidneys has a single artery, and 11% has multiple renal arteries. The score has been calculated and weighted against the gold standard, the intraoperative assessment by the surgeon. The surgeon's subjective experience has been evaluated by rating 8 critical phases during the procedure, including the difficulty in mobilization of colon, mobilization of kidney, gonadal vein dissection, adrenal vein dissection, renal vein and renal artery dissection, handling the ureter, and the availability of working state. And the surgeon gives a score, rating from 1 as standard, 2 as moderate, 3 as very difficult, and the sum of these grades define the actual surgical difficulty category. And when the preoperative lab doctor score is weighted against the intraoperative assessment by the surgeon, the authors found the strong correlation between the prediction and reality, with the quadratic weighted kappa indicating substantial agreement, with perfect agreement for the very difficult cases. Also, for the confusion matrix, as you can see, the sensitivity of the score for the standard cases was 83%, for the moderately difficult cases was 85%, and 100% sensitivity for the highest risk. If you can notice, there is some discrepancy in this issue between the moderately difficult and the standard, between both the lab doctor prediction and the surgical assessment. This discrepancy can be analyzed based on that the highly experienced surgeon may perceive anatomically complex cases as easy due to their advanced surgical skills. However, the score correctly identifies the anatomical reality independent of the operator confidence. That's why sometimes you may find the lab doctor often predicted moderate risk while the surgeon rated it as standard. And regarding the impact of the technique, there was no difference at all. There was no difference whether the procedure was performed with pure lab donor nephrectomy, hand-assisted, or robotic-assisted. The score is valid across all the 3 approaches as it assists the anatomy, not the method. Sorry. The clinical application of the score helps for better donor selection. It compared the candidates and select the donor with the lowest anatomical risk score. Also, it ensures the safety. If you are confronted with a high risk score case, you must predict more operative time, and you must ensure the presence of senior staff in the operative theater. Also, it helps for the training programs. For the low scores, it is safe for the residents and fellow to perform the surgery, but for the high scores above 26, the consultant only must be the surgeon for the patient, for the donor safety, and for protection of the trainees from overwhelming cases. Of course, the study has certain limitations, being restricted to Italy, with to somehow not that big sample size, 185 patients, and still the comparator was relying on the subjective surgeon perception. But in the future, the lab doctor score may be validated in international multi-ethnic cohorts, and of course, it must be correlated to long-term graft outcomes and patient recovery metrics. So, to sum up, the lab doctor, a blueprint for safer donor nephrectomy, being objective, it replaces the subjectivity with 11 measurable parameters, accurate, with 100% sensitivity for the high-risk cases, versatile, valid for different approaches of minimally invasive donor nephrectomy, and practical, essential for trainee selection and risk counseling. So it is advisable to integrate the lab doctor calculator into the preoperative workups for precision surgical planning. And finally, my take-home message is the preoperative prediction of difficulty in lab donor nephrectomy should be a concern. Creation of a difficulty scoring system can help surgeons in patient selection to advance their experiences and or to teach fellows from simple to difficult cases. Male gender, obesity, complex vascular anomalies are suggestive of more challenging cases, and the preoperative radiological modalities could be misleading, so the lab surgeon must be ready all the time. Thank you.
Thank you, Dr. Ahmed, for your nice and informative presentation. We will open now the floor for discussion for questions for Dr. Ahmed. Any question? Okay, Dr. Zahran, please go ahead.
Thank you.
Thank you, Dr. Ahmed, for this elegant lecture. But between us, you are a laparoscopic surgeon, and even Dr. Ahmed Harraz, all of us doing donor by different technique, open laparoscopy and hand-assisted. What parameters really impact your decision, or you expect the difficulty during donor nephrectomy? Because all of us know what the factors. We can detect it from the start.
I do believe
Away from this all
yes, yes.
parameters.
Two main concern: the body mass index of the patient. Sometimes the patient is rejected for the very high body mass index, and the complexity of the vascular anatomy. These are the two main concern we
And
rely
the
on.
and third one is male patient with high body mass index. You
Yes.
expect that the fat is adherent to the
Yes.
kidney. So I think this scoring system is much يعني, for
Theoretical.
publication more than the clinical scenario. The most
It's,
important is
it
the
was my-
obesity.
It will be what it was about. I was about to say that actually.
Yes,
Yeah.
it's
From your
the
personal
vascular
point of view, Ahmed, do you
complexity
see
and
that,
the brenephric fat.
It's
there
quite
is
complex.
clinical applicability for this lab score in your own practice? Because we usually know that if you have a scoring system, you need to be simple and fast to calculate. But if I exhaust myself for multiple parameters and need measurements and need work to just achieve the score and then to risk stratify according to this score, I find it a little bit difficult to implement practically. What do
Yes.
you think?
I do believe it's theoretical score, as you said, for publications and for the basic research. But in fact, in clinical practice, as you mentioned, you need simple data, which you can simply rely on to assess the difficulty of your case and to assess your plan while you are performing the surgery. And as we mentioned, the male gender with high body mass index and complex vascular anatomy, these are the most important parameters I rely on prior to proceeding with labdominal nephrectomy. So I do agree. It's more theoretical than practical speaking about that scoring.
For Dr. Zahran, do you have any other comment for your cases if you select the case? Okay, we will have the question first, please.
Yeah. The history to be involved in the scoring system. The scoring system, the aim of the scoring system to assess the difficulty of the procedure and who will or can perform the procedure. Okay. I do believe that detailed medical and surgical history are more important for selecting the case from the far beginning, to assess whether this healthy individual is suitable to be enrolled in the donor nephrectomy, in the transplant program or not. It may not have that quite implication on the difficulty of the procedure. It's from the far beginning whether I'll accept him or reject him as a candidate donor. I think the detailed medical and surgical history will be valuable in such issue, not for a scoring system to assess the difficulty of the procedures. The scoring system, you already have chosen your patient and you try to predict whether the surgery will be easy surgery, moderately difficult, or difficult. This helps to theoretically choose who will perform the surgery. Is it acceptable for training or not? The possible complications that may happen. I do believe the score assess such parameters, but the history, whether medical or surgical, affect your choice from the far beginning whether this healthy individual is candidate for transplantation or not.
Dr. Ahmed, may I ask you, since you have read the paper very well, did they rely on statistical models to drive the score, or it is just consensus between the experts to give grading to each of these parameters, the 11 parameters?
Just a subjective analysis,
Yeah.
and they mentioned it as in their limitations.
Yeah, because usually when we develop a score, we need to do in the appropriate way is to do a prediction model for the complication, for example, and the factors that are significant for predicting this complication statistically, we will grade them and give them scores, and this will be the final score. It is much more objective rather than we expect that this point will be difficult, so we give it a higher score rather than this one.
Hmm.
So they didn't use statistical models for the development of this
No.
score. Okay. Do you have any other like tips for the difficult case scenarios during laparoscopic donor nephrectomy you can give? Uh,
Before proceeding to your next question, I think in a score or model, as you said, it, it needs a large retrospective series to drive from, and then you put the score. You may revise your knowledge, Dr. Ahmed. I mean, you can recheck once again from how this score was made. Are you sure that it is just expert opinion?
No,
Yes, yes, because they used the 185 patients only, Dr. Bilal. It is very difficult to draw a statistical model from just
From this
185.
little
Yeah.
number.
Yes,
Okay.
they mentioned it in their limitation.
In what?
They mentioned that in their limitation.
In their
In limitation.
limitations.
Yes.
Okay.
Usually we have this dilemma of how to start laparoscopic donor nephrectomy, because we know that laparoscopic donor nephrectomy, basically we are dealing with normal tissues in a normal individual, so ethically it is very high risk procedure, but technically it is still straightforward procedure. So my question for you, Dr. Ahmed, you can give an advice for the audience for some of the tips that you would suggest for difficult scenarios. For example, I know that some cases when you reflect the colon still keeps not fully reflected and covering the hilum. This is one of the common scenarios. We have also a problem when you trying to dissect the fat of the kidney. The fat is adherent. Also, this is a normal person. What do you do in such cases? Yeah, we need your advice for the audience.
First of all, as you mentioned, Professor Ahmed, the donor is healthy individual. You are dealing with a healthy individual, and any major complication that may encounter, it affects a whole family. It affects the donor and recipient. So, before the start, not any person is candidate to be the surgeon for the procedure of laparoscopic donor nephrectomy. I do believe if I'll be the surgeon, I must have a quite good experience first with laparoscopic ablative procedures. Lab nephrectomy, simple, radical, even lab adrenalectomy. I must have gained a good experience of dealing with a pathologic kidney in order to come up with some plans to face any unexpected mishaps that may develop intraoperative. I don't know how to say that in such words, but with the experience, you can handle what may happen during the procedure. Sometimes, when I'm confronted with very thick adherent fat, I do tell myself there is no need if I'm trying to dissect the fat from the kidney. Subcapsular hematoma may develop due to the tension on the renal capsule. So there will be no problem to dissect the kidney in the plane of the radical to have the fat, to keep the fat on the kidney, for example. Sometimes when the hilum is covering, I start the section totally away from the pedicle in order to get into some plane that helps me to reach to the pedicle. Sometimes I'm confronted with extensive, this is classic scenario. I really don't know why in lab donor nephrectomy, extensive lymphatics around the pedicle. I start from the aorta itself and dissect and coag with the ligature the lymphatic trunk and peel it off the aorta till I reach the ostium of the pedicle. I tend to avoid dissecting of the artery itself to avoid spasm, or even to go up to the hilum in order to avoid reaching into the sinus fat. So I manipulate myself. As I mentioned, I cannot to translate these facts into words, but I manipulate myself based on the situation. I do believe with some videos I can provide such things, and I do believe in Dr. Muhammad Atiyah lecture will provide us with some technical challenges that have been developed and we have confronted with during the procedure.
Okay, having said that, we thank you so much, Dr. Ahmed, for your nice presentation and richful discussion. And we can now invite Dr. Muhammad Atiyah for presenting some interesting cases.